Good day, everyone, and welcome to our webinar on pandemics, vaccines, age, and global justice. I'm Dan Sulmacy, the Acting Director of the Kennedy Institute of Ethics here at Georgetown, Washington, D.C. Thanks for tuning in to all of you. You're part of a really large, diverse, and international audience. As of this morning, we had 700 pre-registrants or more. And I wanted to let you know that this is a continuation of a conversation we began at the Kennedy Institute a few months ago when we had a webinar called Pandemic Means the Whole World, COVID-19 and Global Justice. Our point then, as it is now, is that the cry for justice is global. It's not just local. And while wealthy nations in the Northern Hemisphere like the United States can debate how we ration ventilators or ICU beds, we have to recognize that most people in the world will never see a ventilator or have access to that kind of advanced medical care. The vaccines, however, are different. They're relatively cheap, low tech, and their aim is actually to prevent disease. The lives of millions of people around the globe will depend upon how we distribute a vaccine for COVID-19. Yet even with the best manufacturing techniques, we recognize that no vaccine can be made available to everyone around the world at once. Initial supplies are certainly going to be limited, and this raises the question of how such a vaccine ought to be distributed. Almost everyone would recognize that it would be selfish or even foolish for the nations that develop vaccines for COVID-19 to hoard them. But this raises serious concrete questions about how best to divide limited supplies of an eventual COVID-19 vaccine among the many peoples of the world. The overarching questions concern the material principles of justice itself. What is fair? What's beneficial? What do the peoples of the nations of the world owe to each other? And in particular today, although not exclusively, we want to concentrate on what role age plays in prioritizing how to distribute vaccines. And joining us today to discuss these very weighty issues are Professors Henry Richardson and Nancy Jecker. Our format today will be as follows. Henry and Nancy will each speak for about 25 minutes. Each will then have 5 minutes to respond to each other's presentations. And we'll then have 20 minutes for them to discuss questions from the audience. We invite you to send those questions using the Q&A function on the Zoom, not chat. Our Kennedy Institute staff and I will then collate the questions and direct them to the speakers for their responses. And I'm going to wrap things up at the end. So let me take this opportunity to introduce then our first speaker for the day, Professor Henry Richardson. Professor Richardson is a professor of philosophy at Georgetown University and a senior research scholar here at our Kennedy Institute of Ethics. His books include Democratic Autonomy, Moral Entanglements, the Ancillary Care Obligations of Medical Researchers, and Articulating the Moral Community towards a Constructive Ethical Pragmatism, all from Oxford University Press. Henry was editor of the journal Ethics from 2008 to 2018. During 2019 to 20 as a Guggenheim Fellow, he was at work on a book project on the division of moral labor until this pandemic hit. His attention was turned, understandably, to today's topic. On a personal note, I want to recognize that Henry was my very first professor of ethical theory here at Georgetown when I was a graduate student. I'm delighted to continue learning from him today, as you also will. Henry?
Thank you, Dan, and thank you for that introduction. We do go back a ways. So I'm delighted to be able to talk to this broad group about the fair international allocation of any eventual COVID-19 vaccine that may be proven safe and effective. Maybe there'll be more than one, maybe just one, we don't know. I spent the summer working on this paper with this amazing group of authors on this topic, and it was a very diverse group in many respects, including people of multiple generations, which was nice getting different perspectives. So I'll speak to the paper, but I'll focus mainly on the parts that I had most to do with, which were the shaping of the constructive proposal with its three-phase structure and its focus especially on averting premature death. So what's the problem here? It's worth pausing on the shape of the problem. It's a problem about fairness and equity, and people were saying early on that we need a fair and equitable global distribution of any vaccine that results. The first quote is from the leaders of the Vaccine Alliance. The second quote is a bunch of prime ministers and other world leaders saying this. And the question is, what would this fair and equitable distribution of a vaccine look like? Well, it became clear early on that this is not your usual distributive justice problem. For one thing, there's just one commodity being distributed. In the near term, individuals will either get immunized or they won't. Maybe it'll take 2 stages, but they will or they won't. That will last them for a while. We don't know how long it'll last. But by the end of the near term, I'm confident that everyone will have been offered it, in scare quotes, because there are going to be some logistical difficulties, some last mile problems, but the world is committed to making sure that eventually the low income countries will get it. And so everyone will have been offered it. And one of the co-authors put it this way when we were trying to get our hands on the problem, and I was meditating on that, and it occurred to me, well, that's not quite right. Not everyone, because some people will die before the vaccine reaches their country. So taking this all together, then eventually it'll get to everybody, but some will die before it can get to them. What matters then is the timing of the distribution, which countries get the vaccine when. And that led us to think in terms of levels of urgency, and we distinguish 3 tiers of urgency. The most urgent harms are those that are devastating, irreversible, and you can't compensate the individual who is harmed. We could only think of one such harm, which is the harm of death. People who die can't be compensated for having died. You can try to compensate the families, but you can't compensate the dead person. Then there are harms that are almost as bad, that are devastating and irreversible, incurable organ damage as a result sometimes of this disease. Setbacks to education, though, and employment are not actually permanent, but they can outlive the individuals now alive, and so be permanent from their perspective. And then there are effects not to be minimized, but they're less urgent. They're merely devastating effects on health and the economies of the world's nations. Even having focused on the idea of life-saving, this is not your usual problem of allocating life-saving resources. And Dan highlighted this in the introduction, but let me reinforce the point. So we're not talking about hospital level allocation to individuals. We're not talking about national level allocation to hospitals or localities or states. We're talking about global allocation, which goes typically to countries. And that means that there's going to be a need to deal with data at a highly aggregated level. And it also means that we have to take account of the huge diversity in the world in all sorts of relevant circumstances. So there's a tendency, for instance, to think about prioritizing, for good reason, to think about prioritizing the frontline healthcare workers. But we have to be careful not to think about the whole world as being like our country, as Dan was saying. So some places have lots of doctors and some places don't. as this almost 20-to-1, around 21 difference in the ratio of doctors to people in the US and Ghana shows. And there's similar differences in all kinds of aspects of life. For instance, how many people live together under one roof as an extended family or not, how many people are involved in the very vulnerable informal sector of the economy or not. Heading into this problem, we also have to think about the supply. We can only really give guesstimates in the manufacturing. We don't know what the vaccines will be, but these companies are saying that they're gearing up for it. So maybe in 2021, if a vaccine is proven safe and effective early enough, you could get hundreds of millions of doses manufactured, and an optimistic estimate for 2022 would maybe be 2 billion more doses. That's still a lot less than the 8 billions of people in the world. What about the availability of doses for fair and equitable allocation? The COVAX facility, which has been created by WHO, the Vaccine Alliance, and the Coalition for Emergency Preparedness Innovation, which is an anti-pandemic group, gotten together and made a multilateral international institution that is got 150 countries or so bought in already to share risk about their investment in vaccines and to make sure that the vaccines are made available to the low and mid-income countries. There are also some pharmaceutical companies that have said that they would like to allocate the vaccine fairly and equitably across the world if someone would just tell them how to do that. AstraZeneca is a company that's done that publicly. And then we argue in the paper, but I'm not going to go into it here, rich nations are obligated not to give their citizens absolute priority. Perhaps it's fine and understandable for them to give their citizens some priority, but there's countries that have control of the source of vaccine or have contracted for it, have some obligation to consider the rest of the world. So these kinds of agents in the green here, these are the agents to which we're addressing our paper. So we got the shape of the problem. What kind of ethically relevant information should be considered in this allocation? Well, a great start has been made by WHO ethics experts and has been taken up by the COVAX facility as articulated in this paper from September. They've got a two-phase system where in the first phase, vaccines go to every country in the world, enough to cover 20% of each country's population. So they go proportional to population of the country. This is about 1.6 billion people. So this is a phase that is going to use up or would use up about the first year and a half worth of production, given the estimates I gave you before. And then only after that would consideration of varied epidemiological risk come in. And that's even, as you'll see, a relatively narrow slice of the information that you might want. So this proposal is definitely better than the rich countries hoarding the vaccine, making sure that it gets to every country. The Gates Foundation has funded some modeling that showed that that would save almost twice as many lives as the rich countries hoarding it. But the world can do better than this. And the world can do better than this by adding in consideration of where the vaccines can do the most good now, or when the allocation is being done. And by also taking consideration of which countries start by bearing unfair disadvantages. So the most obvious ethical principle relevant here is that of benefiting people and limiting harm. It's individuals' lives, health, and well-being that are at stake, and the more life years saved, the greater the benefit. Any allocation should first take account of where vaccine doses can save the most life years, saving or averting premature death being the most urgent concern. So now, given current data, if you sent doses to Peru or Argentina, which are having terrible trouble with the virus, that would save a lot more lives than doses now sent to New Zealand or Taiwan, where they've got very few cases, let alone deaths to worry about. Just wouldn't do that much good in those countries now. It's important in applying this kind of information to be very open-minded about all the different ways that vaccine can benefit in the relevant respects. Primarily now in respect of saving lives. Vaccine can save life years in many different ways, including averting deaths from a variety of causes. So of course there's the obvious central cause, which is death from COVID-19, but what we've seen already from healthcare systems being overwhelmed by the pandemic is that causes people either voluntarily to avoid, they're afraid of going to the hospital, or the hospital is overwhelmed. In any case, people's ordinary healthcare gets disrupted. And if they're needing regular care for HIV or tuberculosis or some other disease that needs regular care, and if they don't get it, they might die, that can be a cause of death. Another pandemic cause type of death, is death from shutdown or reduction of economic activity. We've seen starvation deaths in India, and Oxfam put out a report this summer estimating that as many as 12,000 people per day could die from hunger linked to the pandemic, potentially more than would die directly from COVID-19. Another important thing to be open-minded about is your strategy in steering the vaccine. You could try to name groups that are the most vulnerable, the elderly, those with certain comorbidities, or you could use a strategy of vaccinating those who are most likely to spread the infection. And of course, you could do both. Now I turn to the importance of prioritizing the disadvantaged, especially when that's important domestically also, but now taking the world perspective, we can look at, for instance, these disparities in life expectancy. Taking the 2019 data, Japan, as is usually the case, has the highest life expectancy at birth of almost 85 years. And the Central African Republic had the low life expectancy of just over 53 years. I would assert that these disparities are not fair. By that I mean they do not establish a fair baseline for distribution. One could have a long discussion about what may mean that it doesn't count as a fair baseline, but I think that it doesn't is clear. This life expectancy disparity is also related to different national age patterns in COVID-19 morbidity. This chart dramatically shows that the poorer the country, the younger the people dying from COVID-19. This is all these different nations, and here's data from a study done in India that followed millions of people being contact traced in 2 different states within India. And this shows dramatically different pattern in the ages of death from COVID-19 in India compared to the United States. In the United States, it goes up by age. In India, goes up to the 50 to 64 cohort and then back down again. Also, since we need to worry about the economic costs of the pandemic, we need to worry also about the economic disadvantages around the world in income, and maybe even more importantly in absolute poverty. Absolute poverty is linked to the disparities in life expectancy or in age of death by this study, which suggests that a good part of the international disparity in lifespan or life expectancy can be traced back to, or if you drill down to, See, why is that fully? It has a lot to do with the differences of status within the low and mid-income countries. So the low status, the really poor people, are the ones who have the lowest life expectancy and die at the youngest ages. So the model that our paper proposes is called the fair priority model. What else would you call it? It proposes 3 phases based on tiers of urgency, the tiers of urgency that I set out before. So the first phase aims to minimize life years lost, adjusted for disadvantage in a way I'll explain in a moment. The second phase keeps that life years lost concern, but adds in 2 economic concerns and also concern with irreversible health damages. And then the third phase is a broad phase dealing with reducing the infection rate as far as can be done, and hopefully below an RT of 1 in all countries. Right, so for the first phase, we propose a metric to use that does adjust for disadvantage, and that's the metric of reducing standard expected life years lost. This may not be a familiar term to everyone, but it is commonly used in assessing the global burden of disease. And this is a measure of life years lost that's globally uniform, and it's based on a life expectancy table based on the Japanese life expectancy table. That again is where the highest longevity or highest expected longevity of anyone at any age is found. So using this global standard assigns the same value or the same cost to any premature death, regardless of where anyone lives. And it will count a death at an older age as a lesser, it will count the averting of a death at an older age as a lesser gain than averting a death at a younger age. But it will always account averting the death of anyone at any age as a gain. So taking this example from the standard table, the death of a 93-year-old is counted as a loss of 4 standard expected life years. That's how long someone in Japan effectively expects to live. So a 93-year-old can expect to live on average in Japan. Just to make sure this point gets across, I'll give you another illustration. So these are the life expectancies of 50-year-old females in France and in Ethiopia, which are significantly different. If you ask the question, what's the SEYLL for someone in Ethiopia, it's actually higher than the figure for France. Why? Because the life expectancy in Japan is higher than it is in France. But that's the life expectancy that will be assigned, or that will be the number of life years assigned for the death of a 50-year-old anywhere. So the aim of the fair priority model in the first phase is to allocate doses of vaccine so as to minimize foreseeable premature deaths by all causes, measured in terms of standard expected life years lost. For phase 2, we've got 3 measures, keeping the standard expected life years lost, which can now in this phase also be considered as a proxy for morbidities, namely those morbidities affecting life expectancy that will show up in that measure. Second, reduction in absolute poverty, which we propose be measured by the poverty gap, which is a measure of the mean shortfall of the poorest people from the chosen absolute poverty line. We thought, and this is a good example of a place at which in our paper, which is fairly short, but is also coming sort of early in this process towards implementation, we thought it was not our place to choose a specific absolute poverty line, whether $3.10 a day or $5.30 a day, but that the implementers should and we'll need to work out those details. And then finally, there should be a broad measure of the economic costs. We suggest gross national income. This is a broad proxy for the effect on well-being to people, and specifically captures the non-health well-being. And it also will capture spillover effects to other countries, which is important because we have an interconnected economy. And in the final phase, we have the obvious measure of lowering the reproduction rate of the infection until it gets hopefully below 1. So before closing, I'll briefly consider 2 objections. I'm sure you've got lots of objections for me, and I look forward to those. But the first one is that it's unfair to countries that have controlled the infection through sacrifice to make them wait for a later phase. And my first answer is, well, they can relatively well afford to wait if they've got the infection under control, and they can count on getting the vaccine later, in a later phase. And if they have incurred severe economic losses in keeping infections low, then the vaccines won't much help them with that because their infection rate is low. So the vaccine will have diminishing returns on what they can do to help the economy, certainly. And what should happen is that these countries should tap other sources of economic aid, such as World Bank loans. And the World Bank is gearing up to make lots of loans available. And the fundamental answer, though, is that we believe it's unjust to make individuals pay for the corruption or incompetence of their governments. So countries that have been incompetent, like I'm afraid to say United States or Brazil, is that incompetence on the part of the governments shouldn't be visited on the individual citizens, even in a reasonably functioning democracy like the United States. It's very hard for individuals to control anything that's happening at the top, as we've been discovering. The second and last objection I want to take is that it's unfairly ageist to count life years averted. It's discrimination against the elderly. A first point is that older people have had the benefit of more years of life. Another worry I think that sometimes people have about counting the life years is that it's failure to respect the value of everybody's life equally. But it's not a question of evaluating anybody's life. That's sort of a whole lifetime thing. It's a matter of assessing a delta. It's a matter of affecting how much of a gain is involved in averting a given premature death. And reduction in life years lost well measures that. And I remind you that on the standard we're using anyway, averting anyone's death is counted as a gain irrespective of their age. So rather than having a truncated view of the human lifespan and say, not counting a death after a certain age as a loss that matters for these purposes, using standard expected life years lost reckons every death as a loss, and it does so by reference to what's currently the highest achievable human life expectancy. So I look forward to your questions and objections, but I want to close by thanking all my co-authors, especially Zeke Emanuel, Govind Persad, Adam Kern, and Ola Nurheim.
Thank you, Henry. That was terrific. Now we have a chance to hear a different perspective on the same topic, both from philosophers who are very interested in the questions of justice, and particularly global justice. The second speaker, Nancy Jecker, is a professor of bioethics and philosophy at the University of Washington School of Medicine. She holds visiting professorships at the University of Johannesburg Department of Philosophy and the Chinese University of Hong Kong Center for Bioethics. Her research explores individual and societal aging with attention to justice, human dignity, medical futility, and global perspectives. She's published over 200 articles and 4 books. Her most recent is entitled Ending Midlife Bias, New Values for Old Age. While she may not remember, Nancy and I first met in 1988 when we were both panelists responding to Norman Daniels on the question of justice between the generations. That became, of course, a major part of Nancy's career. It wasn't for me, and I'm not even sure that we've even actually, Nancy, seen each other in the intervening years, and the pandemic is unfortunately making our reacquaintance virtual rather than real. But I've followed your work over the years with great admiration. I'm certain you're going to add immensely to our discussion today, and I'm pleased to introduce you to our audience.
Thank you very much, Dan, and good afternoon to good morning to everyone. It's a pleasure to be here. I want to thank the Kennedy Institute of Ethics for hosting this event and for inviting me to share ideas on this important topic. My presentation is based on a paper written to colleagues at the University of Washington School of Medicine, Drs. Aaron Whiteman and Doug Dikema, and both the paper and my presentation are titled Vaccine Ethics, Global Priorities for the Just Distribution of Vaccines Against the SARS-CoV-2 Virus. And I'm going to begin with a series of questions. We know all too well the COVID-19 pandemic is deadly. Every day, the virus strikes about 250,000 of us globally, and it kills 5,000 people. If a vaccine against the virus becomes available, which is expected, what is a just and equitable way to distribute it? Should we give priority to young people who have not yet had a chance to live their lives? Older people who are at greater risk of severe disease and death? If we distribute vaccines globally, how do we weigh the fact many low-income nations, people of any age who become critically ill may have little or no access to life-saving technologies? Our proposal answers these questions by prioritizing frontline and essential workers, people at high risk of severe disease or death, and people at high risk of infection. We propose that the distribution of vaccines to priority groups should take place at a global level. And in this presentation, I'm going to focus mostly on older adults because this part of the broader proposal has generated controversy. And it is also a point of difference between my colleague Dr. Richardson and I. And there are 2 main arguments we offer for prioritizing older adults. And interestingly, neither of these arguments appeal directly to age. We should help people with the greatest need. And during the current pandemic, it entails prioritizing older adults. As a group, older people everywhere face far higher risk of severe disease and death. This slide, for example, shows cumulative US hospitalization rates based on age groups, with people 65 and over experiencing far higher rates of COVID-19 associated hospitalization compared to other age groups. They're that red line right at the top. Older adults also have higher case fatality rate around the world. The COVID-19 death rate in the US, for example, exceeds 10% for people in the age bracket, which is the 85 plus group. Why are older adults facing this level of risk? There are a number of reasons. First, biology. Age-related decline in immune response renders older people less able to mount an effective defense against the virus. Another reason is that older adults have higher rates of certain underlying chronic conditions, which are associated with COVID-19 morbidity and mortality. There are no doubt social determinants at play as well. Congregate populations in general fare worse, whether in prisons, homeless shelters, or long-term care facilities serving older clients, because physical distancing to contain disease spread is different. Other social determinants relate to major deficiencies in elder care facilities. Prior to the pandemic, for example, the US Government Accountability Office reported shortcomings in infection prevention and control practices at US nursing homes and long-term care facilities. They found that 82% of facilities showed a deficiency during the study period. Examples included practices we now know are critical to preventing spread of any virus, such as not using proper handling, failing to isolate sick, and not using masks or protective equipment. Additional factors relate to working conditions of employees at their care facilities, who may need to work in multiple facilities to meet increasing the odds of disease spread. Yet, as mentioned, an argument based on helping those with the greatest need does not make any explicit appeal to age. And older people are hardly the only ones at heightened risk. Consider two cases. The first is a 70-year-old man with type 2 diabetes who is affluent, lives at home, and can socially isolate. Contrast his situation with that of a 19-year-old man who lives in a crowded homeless shelter. How ought we weigh these different types of risk? Giving priority to people with high risk of severe disease or death, like the 70-year-old man with type 2 diabetes, is consistent with how the US and many other nations distribute influenza vaccines during pandemic shortages. For example, the most recent 2018 CDC guidance prioritizes people age 65 and over people age 19 to 64 for influenza vaccines. They fall within a high-risk group for serious disease or death. When we turn to people at high risk of infection, like the 19-year-old man who lives in a crowded homeless shelter, our focus shifts to social determinants, including socioeconomic class and systemic racism. For example, in the US, Black and Latina people are proportionally affected by the SARS-CoV-2 virus. They have triple the chance of becoming infected compared to white people. Others at high risk of infection are people living in crowded environments and people who cannot work remotely. Assigning priority to vaccines to people at high risk of becoming infected has not generally been part of official policies for vaccine distribution. However, it should be. The reason is that people at high risk of infection have greater need for vaccines. Building on the National Institute of Minority Health and Health Disparities definition of disparity population as a population displaying a pattern of poor health outcomes indicated by over rates of disease incidence, prevalence, morbidity, mortality, or survival compared to the general population. We define a COVID-19 health disparity population. So this is a disease-specific health disparity population as a population with poorer health outcomes as indicated by higher risk of severe disease or death, infected with the SARS-CoV-2 virus, or a higher risk of becoming infected. We propose giving COVID-19 health disparity groups so defined the highest priority for vaccines immediately after frontline and essential workers. Within this population, the health disparity, COVID-19 health disparity population, we assign the top priority to people who are at high risk of both serious disease or death and high risk of becoming infected. For example, if the 19-year-old I mentioned a moment ago had a BMI of 30 or more, he would fall into what we're calling the highest priority category because he would have both a high risk of serious disease or death and a high risk of becoming infected. Likewise, if the 70-year-old in our example resided in a nursing home, he would fall into the highest priority risk group because he would have both a high risk of severe disease or death and a high risk of becoming infected. The next priority is people with high risk of morbidity and mortality from the virus, but who are not at high risk of infection. For example, the 70-year-old in our original example who lived independently at home is unlikely to become infected, so his priority is relatively less. Lowest priority within the COVID-19 health disparity group is people with high risk of infection, but no other known high risk factors. For example, the 19-year-old in our example might fall into this category if he had a normal BMI and no other risk factors for severe disease or death. I turn next to a second argument for prioritizing older adults. And again, it does not appeal directly to age, it appeals to the goal of saving the most lives. The argument begins with a very important observation. The observation that when the good being allocated is a life-saving resource such as ventilators, saving the most lives translates to prioritizing those most likely to survive. However, so if they receive the resource, they're most likely to survive. However, when the good being distributed is preventive, such as the vaccine, the logic of saving the most lives is turned on its head. In the case of vaccines, saving the most lives implies selecting those most likely to die. Notice that saving the most lives does not, as I mentioned, make a direct appeal to age. However, during the COVID-19 pandemic, saving the most lives implies favoring older people because they are the group with relatively higher rates of mortality and morbidity from the virus. By contrast, the 1918 influenza pandemic, which caused the deaths of 50 million people, was disproportionately fatal among people ages 20 to 40. Under those conditions, saving the most lives implied prioritizing younger adults for vaccines, since they had lower chances of surviving if infected. I want to turn next to some possible objections to our proposal. And I'll begin with the objection, which is based on global health equity. Critics could claim that during the COVID-19 pandemic, helping the needy and saving the most lives violates health equity. And the concern here is that high-income nations have more older residents and higher average life expectancies. And that gives them an edge over low and middle-income countries, which have fewer older residents and shorter average life expectancies. Yet in reply, arguments for helping the needy and saving lives make a broader appeal. In low and middle-income countries, many social conditions place people at high risk of infection and death. For example, African nations with limited ventilators, ICU, and specialist physicians to care for critically ill patients merit vaccine priority because people of any age who become critically ill without access to these resources are more likely to die. Other risk factors for infection in low and middle income countries may include population density, especially urban crowding, and living or working conditions that make social distancing difficult. Another objection to our proposal holds that rather than saving the most lives, we should instead save the most life years. Specifically, we should minimize life years up to a standard expected number specified by reference to the lifespans of economically developed nations as a norm toward which populations aspire. And this comes right from the argument that Dr. Richardson presented a moment ago. We want to argue that such a proposal is explicitly biased in favor of younger people. As Dr. Richardson and colleagues put it in their paper, averting a death at an age is counted as a lesser gain. Let me say that again, averting a death at an older age is counted as a lesser gain. Why? The reason is that people at younger ages have more years left before reaching the standard number. For example, if the standard number is 75, a 20-year-old has 55 years prior to reaching the standard. So those years that count. A 60-year-old has just 15. The devaluing of later life is discussed at length by Emmanuel in a solo authored paper published in The Atlantic. He wrote that it's downhill after 75. By old age, he claims, all the creativity has been, quote, squeezed out of neural networks, and we are unlikely to achieve great things or generate creative thoughts. Going back to the paper by Emanuel and colleagues, they also appeal to consensus, holding that there is what they call a popular agreement that deaths that prevent people from realizing goals earlier in life are worse. Yet in contrast to these utilitarian calculations, sub-Saharan African conceptions of the value of life in old age hold that the older a person becomes, the more interwoven they are in a web of relationships and the greater their capacity for moral excellence. Surely diverse views of people around the world should be part of that so-called popular agreement when we're formulating policies for global vaccine distribution. Yet in defense of discounting older life years, it's been argued that older people have lived a fair innings. Churchill, for example, writes that as an elder, he has already, quote, been offered many opportunities and enjoyed much happiness. And he adds that in both healthcare access and career opportunities, I have been favored. Yet what if someone had been subject to deprivation throughout their life? Have they had a fair innings? For example, contrast the situation of Churchill with an older person of the same age who has lived a life of deprivation with meager opportunities. The second person might not agree that they have had a fair innings. This suggests that age is not the only salient consideration determining fair innings. Is the second person obliged to step aside? For some, stepping aside only perpetuates a pattern of injustice experience throughout life. More broadly, whether someone had a fair shake depends not just on the number of years they have lived or the stage of life they occupy, but also what those years and stages were like. Finally, it is worth noting, I think, that fair innings is a metaphor. It compares life to a game, specifically a team sport. And the game analogy is not dental, it packs in a whole set of ethical assumptions. First, games have rules that tell us when play starts and stops. A game properly ends after playing for a set period. In cricket, for example, play ends after the last of a set of innings. You don't stop the game at any other time. Second, viewing life as a game leads us to think of fairness as playing by rules. This suggests that lives a shorter life than the rules allot, they are cheated. When they live longer, yet they want more, they are greedy. Third, team sports instill the value of taking turns. Each player is on the field for an allotted time, steps aside to wait for the next. Carried over to life, this suggests that individuals ought to take turns living, and by age, our turn is up. Notice how different the assumptions would be if we introduced a different metaphor, say comparing life to a story. There are no preset rules that tell us how long a story should be. We celebrate stories of different lengths. Viewing life narratively leads us to think of each part of life, each chapter of life, as making an essential contribution to the whole of the story. In closing, our proposal for justly distributing vaccines against the SARS-CoV-2 virus requires first, prioritizing frontline and essential workers. Next, prioritizing those who are at high risk of severe disease and death or at high risk of infection. And last, the general public. I want to thank you very much for your attention and I look forward to the Q&A.
That was a terrific presentation from both of you. Now, in the interest of justice and fairness, Henry gets a chance to first respond to Nancy, and then we'll let Nancy take a few minutes to respond to Henry, and then we're very anxious to get to your questions. So Henry, please.
Okay, well, that was fascinating and very powerful presentation. And I think a lot of that's very attractive. Focusing on these populations or groups is very attractive for doing allocation at a national level where you have enough information. But I think the global variation in things like how older people are treated, whether they're living congregately or not, all these variations among nations makes it really hazardous to try to think about groups or populations, as you were calling them, in the international level. It's better to look at the data about how things will come out. That'll require some modeling, but I think it's important to do. And also, this focus on groups tends to minimize the importance of, I take it you're talking about vaccine going to those groups, but as your own colleague Joshua Schiffer pointed out in the pages in New York Times lately, that one way to protect the lives of the elderly may be to stop the spreading that's around them so that they become less at risk of becoming infected. And then, so Zika manuals got a lot of play for that Atlantic article, but that was more focused on the prudential perspective of whether one is making one's life worse by continuing to buy into medical care. Maybe it's better from the individual's point of view to leave all that medicine alone. But in any case, although he was the lead author on our paper did not buy into a fixed endpoint that was the target. That's the whole point of the fact that somebody who's at 94 years old still expects to live, based on the Japanese table, 4 more years. There's always more to be lived. And that's got to be counted. The narrative isn't over till it's over. And one more point just about it's a powerful difference about, you point to about in some cultures, the older people are valued more and they're seen as more interwoven in the culture. And that may be because since they're not living congregately, maybe they are more interwoven. But I have a hesitancy, I don't know if my co-authors share this, but a hesitancy, especially in a global emergency, in getting into this kind of judging of the value of an individual's life, whether it's more valuable because they're interwoven or less valuable because they're not tied in with other people. I think, especially in an emergency like this, it's the saving of their life that matters, but saving life is just prolonging life. Everybody dies. And so you need to look at what's the magnitude of that gain if you save a life. And I do think that is well measured by life years lost. So I wasn't making the fair innings argument. I was making that claim about how do you understand the magnitude of a loss when someone dies.
Hey, Nancy.
Thank you very much, Henry. I just want to make a couple of comments. One is I think Henry and I both share the goal of benefiting people and limiting harm, and we interpret those broad notions differently. Dr. Reed and colleagues focus on life years saved. So they interpret benefit in terms of how many life years can we save, and in particular, how many life years can we save before a sort of standard number, and using the model of a developed nation as the goal. By contrast, Drs. Whiteman, Diekema, and I interpret benefiting people as saving lives. And when we talk about benefit, we are talking about saving the most lives and helping those with the greatest need. And those are our priorities, and they result in a very different focus, because if you're saving lives, you're not concerned about life years saved prior to a standard number. You're focused on saving lives. You're focused on that conception that Dr. Reed mentioned right at the beginning of his presentation, that are certain harms that are devastating, irreversible, and non-compensable. And death is one of those. And so that would argue for saving lives, because when lives are lost, that is the most awful of harms, devastating, irreversible, and non-compensable. So again, the focus, it leads to very different recommendations and priorities in terms of the allocation of vaccines. If you're saving life years prior to a set number, you're going to get a different result. And if you're just trying to save the most people and not weighing more heavily those are different. The whole notion of a premature death backs in the assumption that there's a standard expected number of years that we should live. It's the game analogy of we have a certain set of rules and they allot us a certain number of years. And to ask for more than that is greedy and grasping, and to get less is to be gypped. And so I'm sort of shifting the metaphor here, and I'm also interrogating the metaphor for the value assumptions that are implicit within it, I think, and focusing on saving the most lives of those assumptions, which are controversial and which people around the world do have quite different views about. So I don't think the argument that we are making rests on a particular view about the value of life in old age, the value of, and we're not prioritizing lives before a standard expected number. We're prioritizing all lives. And I'd love to hear what the audience have to say.
Maybe we could have we have a couple of minutes before we start. Maybe Henry, if you want to respond quickly in 1 minute, and Nancy can respond back, and then we'll go to Q&A, because we've already generated a little bit of discussion here, so wouldn't want to let it go.
Okay, well, I just want to say we're not picking a target age and counting deaths only before that. The table, it's a life expectancy table of life expectancy at any given age, of any given age cohort that's used, right? And it's always positive. So the 94-year-old expects to live 4 years more. So maybe if that's, you mean there's a different expected number for anybody at any age that is invoked, that's true. So for a 94-year-old, there's a number, namely 4 more years, that in Japan they're expected to live. And we think by taking the top existing life expectancy that exists in the world at any national level, we're being generous about that. It's not a low number of it's not a low life expectancy to assign for a 94-year-old. But I just want to make sure that people don't get the impression that there is a measure out there that says count only life years lost up to what would be age 85 or something, and not count beyond that. We're not doing that. I just want to be sure that's clear to the audience.
If I could just respond to that. So clearly on your proposal, Henry, all lives count some. Lives count more, and the lives that count more are younger lives because, excuse me, the standard expected number of years left is greater. So the effect of implementing this proposal is to count more certain lives than others, and those are age-based. So this is an age-based proposal in that respect. Every life counts for something, but lives aren't counted equally because your focus is not life, it would be life years.
I can step in as a moderator so this doesn't degenerate into a presidential debate.
Yeah,
I'm sure both of you are very, very respectful. But I think we do want to give some time to the audience to ask their questions, and I'm sure some of those questions will return to the themes that have already been generated here. So one of the questions that arose is who should be deciding all of this, and in particular, sort of corollary to that is, given the current relationship of the United States to the WHO, how does that affect decisions about who decides how to distribute a vaccine on a global basis?
I mean, I don't know if it's worth worrying too much about who should be deciding, because it's just sort of the die is cast in terms of who will be deciding. It'll be the pharma companies that are making the vaccine, the rich nations that have contracted for it or control, have some control over those companies if they're within their borders. And then this COVAX facility, which is the most hopeful thing, which will, I think, do things fairly and have an international look. I think it's really unfortunate the U.S. isn't participating in WHO now. For one thing, it would hedge our bets, since we can't count on the effective vaccine coming out of the United States. But
Nancy, anything to add? Or
yeah, it is very unfortunate that the United States decided to not participate in the World Health Organization. They should be a leading part of the co-leadership of this decision making. It should be as global as it can be in terms of participation from all the member states and from people around the world. They should all be the input. It shouldn't be driven by just one region or one part of the world. Unfortunately, the reality is that these advanced purchase agreements that wealthier nations have made are going to consume a large share of the world's vaccinations, and they won't go first. Those vaccines are part of advanced purchase agreements, won't be available to distribute globally. So there is a real need for cohesion and coming together, joining together to make sure that there is the kind of fair and equitable distribution that Henry and I are really focused on.
Related to that, I'll take the chair's prerogative to ask a question, which is in some ways what's wrong with the COVAX proposal to give it based on proportion of population of countries. It seems to me that that's sort of got an inherent fairness to it in the sense that developing nations tend to be more populous, and therefore some of the health disparities tend to be accounted for in that regard. And if it's in some ways a simple solution, that the most of the public health measures that have been undertaken and that have been very effective have been pretty simple. Things like mosquito nets, wells, World Health Organization rehydration solution. And this would be a lot simpler to just sort of say 20% of your country gets access to the vaccine. And it may also be easier to sell to people because it seems so simple and clear. So tell me what's wrong with it, or how you would respond to COVAX.
Well, it has the illusion of simplicity. Look, one wouldn't send malaria nets to Norway, right? They don't need them. You don't send HIV medications to places without a serious HIV epidemic, and you should send the vaccines to the places that are experiencing the worst COVID problems. It should send them where they're needed. So I think Nancy and I agree on that. They should go where they're needed, and not just flat on the basis of population. Flat on the basis of the population has an illusion of fairness about it, but equal respect and concern for people doesn't require treating all people identically. If their circumstances are different, you should treat them differently. And even, especially the SAGE working group that WHO had working on this, and even the WHO ethics document that COVAX signed on to, recognizes that there may be times where there's a really severe outbreak somewhere and they should depart from that priority to proportional representation, but they don't say when those exceptions would occur. And it's just common sense that if the vaccine is much more urgently needed somewhere, that's where it should go first.
I would agree with what Henry said. You don't just on population because people have very different needs in part of the world. As I argued, it should go to people who have highest risk of severe disease and death, which is based not just on age, but on other social determinants and COVID-19 health population, risk of severe disease or death, and high risk of infection right after frontline and essential workers. I would also just sort of, we tend to lump, when we talk about the distribution of vaccines, we think of vaccines as sort of one thing, but there are going to be many vaccines and their distribution require different kinds of conditions to maintain vaccines, and some are going to be more appropriate for middle-income countries, and some can only be used in high-income countries because of the kinds of conditions under which the vaccines need to be stored. So I think these different priorities, there's other levels of complexity that need to be taken into account. But yeah.
Following that, some of the questions that have come in have been related to it. How are you going to convince the countries that develop these vaccines to follow your plans?
That's a good question. It's a question that relates more to politics than philosophy and diplomacy. I just hope that by the time we get to that point, we have leaders in place that are going to work together, and we will forward. But what we're setting out, or what I'm setting out with my colleagues in this proposal, is aspiration as to what we should start to do, and in which we should go. And there are all kinds of maneuverings that happen that might make the realization of that difficult, but I think keeping that goal in mind is going to be critical as sort of a compass pointing us toward the direction that we want to take.
Henry?
And there's also the point that has been made by a lot of these leaders that none of us are fully safe until the whole world is safe from this pandemic. So it would behoove us, any nation, from the point of view of prudence, to help spread the vaccine around. And thankfully, the nations aren't fully in control. So the pharma companies have some independence on this. And thankfully, the COVAX facility has been started and has considerable resources, so they'll help. Some governments are more reasonable than others.
Right. That's right. Lots of questions are coming in, again, getting us back to the sort of prioritization of older versus younger persons. One asks, how can giving priority to save older people be just when it could be used to save a young person, often in many countries a man, who's the breadwinner for a household? On the other hand, it says sometimes an older person is caring for several generations, so their loss may be devastating to other persons. So, so those are in tandem with each other. How do you each respond?
Well, different countries and different cultures are going to have very different practices, and I don't think talking about a global distribution of vaccines, we can really take that into account at a kind of granular level. I think once we get these broad first pass global distributions, there will need to be more passes that occur at national levels. I think Henry would probably agree with that. But this is sort of the first pass, the global distribution between countries, and then additional passes are going to take into account features that are morally relevant and come into play in different types of environments and societies.
Yeah, and I have to say, when I was putting together my slides, I thought of trying to hide behind that and say, well, I'm just talking about the international allocation, but also as philosophers, right, we're putting forward principles about what counts. So although I don't know how under the umbrella of this international allocation, I don't know how the domestic allocations will be controlled by any of these allocators, but my principles imply, that with a carrying through to some extent to the national level, although at the national level, more information can come in about these variations in housing practices and so on. But I want to come back to the issue of valuing lives and push back on that a little bit, because I don't think a life is what's being valued when you steer a potentially life-saving treatment. A life, again, begins at birth, ends at death, whenever it is. You have to look at the whole. That's how you value a life. And that's not what's at stake here. What's at stake here is how long a life is going to continue for an individual from the present point forward. And so you're looking at how much of to what extent you can extend someone's life, or to what extent you can prevent it from being cut short. And I don't know, that's what's, I think, appropriately addressed by the life year lost. I think the valuing lives differently is a red herring.
Nancy, do you want to respond?
I do want to respond, thank you. So I think what is at stake is lives. And if you disaggregate lives into life years and you say, how many does that leave this person versus, and then you're making distinctions about the value of life at different ages. You're saying that people that have more future life years ahead to live, more life years to the standard expected, that their lives are going to count for less because of their life years remaining. So it's facially neutral with respect to age. It just talks about maximizing life years, but obviously it's not de facto neutral with respect to age. It weighs the value of different lives differently. And I don't think we really save life years, we save people. And I think we need to keep our focus there. And when we're talking about prevention and vaccination, we need to look at who the greatest risk of death if they don't receive this intervention. So as I mentioned in the presentation, it's on its head the usual focus when we're focusing on life resources, we want to know who's most likely to survive. But when we're talking about preventing a serious disease, we want to say who's most likely to die without this intervention. And we're talking about the lives of people, and we're not saying that if you have more life years, you count for more, or more life years until standard expected number, you count for more. No, a life is a life is a life. I would also, just to get to the question that was asked about how to make these distributed at a national level, I would also agree with what Henry said, that I would hope these principles that I'm putting forward would be relevant. They don't stop being relevant at the national level, but I do think it's going to point to different populations, because who's at high risk of infection in one society is going to look very different than who's at high risk of infection in another. So it has to do with the translation of the principles, not the changing of the principles.
One question that came in, which I think might be interesting, is to the extent both of you have thought about whether your model extends to other kinds of healthcare interventions besides vaccines, as a sort of way of justly distributing healthcare resources globally.
Well, one thing that I would underscore in our proposal, we focus on social determinants and health equity. So rather than just looking at high risk of severe disease and death, we're also looking at people that are high risk of infection, and we're defining that with respect to a disease. So we're taking a health population with respect to a particular condition. And who qualifies as being a health disparity population might look different types of conditions. So with COVID-19, it's older adults with severe disease and death, and a broader group of people at risk of infection based on a number of different social determinants such as class and poverty, living and working conditions, and so forth. Look at other conditions that our health disparity populations might look different. But I like the National Institutes of Minority Health and Disparities general definition, and I think we can build on it for disease-specific modeling. So yes, I do think it has broader relevance.
Henry?
Well, I'm not to address the broader relevance question directly, but within our account of how the vaccine should be steered, we do take account of all sorts of other things people might die of as a result of the pandemic. So they might just die because their care is displaced, because the healthcare systems are overwhelmed. They might die of starvation. So, and those are the kinds of things that are going to reflect the social determinants in place where they are. This model that we provided is simplified, I think, by the fact that there is this single commodity being distributed, namely a vaccine. It would be very different if we were talking about health systems design or anything more multifaceted than that. And also the emergency aspect, or the urgent, which is behind our tiers of urgency, might not be present.
Another set of questions came in, going back to a comment you had made earlier, Henry, about not holding people responsible for the corruption and incompetence of their governments. One person has asked how you would justly and fairly measure that, the incompetence and
sorry, what was the verb?
How you would measure the incompetence and unfairness of governments in a just way. And then I can follow that up perhaps with questions about how incompetence and incompetence and injustice within various countries will affect how the distribution goes. But the first one is how you would measure it.
Yeah, well, the point is we're against trying to measure it, right? So that was the point of my ambulance example, that the EMTs who were on the scene to save lives, prevent lives from being cut short, shouldn't worry about that responsibility, and they leave that for the leisure of the police investigators or the insurance investigators that come later, and it's going to be a tricky matter, but it's just something that shouldn't be gotten into. And I think there's no more moral reason to get into this backward-looking aspect. If you had an individual agent who is messed up and they get in trouble, then maybe you shouldn't prioritize helping them, but that's not the situation. We have countries and their leadership, and the people within the countries are not the agents who are settling these decisions.
Nancy, anything to say on that before we move to how corruption and incompetence will affect distribution within various nations?
No, I agree with what Henry said. Once we start getting to these sort of backward analyses trying to figure this out, it's hopeless. So I agree with what he said.
Not helpful. So then the question comes up, no matter what scheme you have or what model you're using for distributing the vaccine across nations, one then has to account for how they will be distributed within those countries, many of which are plagued by incompetence and corruption. And so do either of you have anything to say about that? Does your model help, or is it something outside of the model that would need to be used in order to answer those questions?
And we said something to that. You want to go ahead, Nancy? Yeah, I've been jumping
Go ahead.
in. We said something to that in the paper. I don't know that it follows from the core of the model, but the line we took was that in extreme cases, if you can really predict that the allocation going to a nation will be hijacked by the elite, by the autocracy there, and maybe they'll sell it for gain or something, then don't do it. But those would be extreme cases, and it also points to a responsibility of the world, the rest of the world, to try and reform them, or if it's a lack of technical capacity, like maintaining the cold chain in the transmission of the virus, the transmission of the vaccine, keeping the vaccine sub-zero temperatures, maybe technical assistance is what's called for. So shouldn't take the lack of competence for granted. Maybe it can be ameliorated.
I would just reiterate this distinction between corruption and trying to co-opt the principles and who is to receive a vaccine versus capacity for a distribution in accordance with the principles. Obviously, there are different kinds of evidence that are appropriate for different sorts of shortfalls. And I would hope that the world would come together in trying to enforce in the case of corruption and in the case of capacity building as well.
Another set of questions regards how your models address questions of racial and gender inequity within various societies as you're distributing the vaccines worldwide.
Our proposal addresses it by defining a COVID-19 health disparity population and taking into account thereby social determinants for risk of infection and risk of severe disease and death. And these are not just based on biology, they're based on fact about how conditions under which people live and work, based on issues related to systemic racism, which impacts risk for disease and death, and risk of becoming infected. They're based on socioeconomic class. All of these social determinants come into play when you talk about who's more likely to get sick, and when they get sick, who's more likely to do poorly. And there's been a lot of attention in our conversation to older age groups, but there are many other groups, and it varies from one society to the next, but there's some common threads like poverty and racism that I think are present all around the world that are going to place people at greater risk. And by focusing on who has the greatest need, understood in terms of highest risk of severe disease and death and highest risk of infection, we are in, the proposal is set up in such a way to model taking that into account. So I think that's a really critical point, and I think it needs to be part of any global distribution plan, because it's not been, we haven't done well with respect to that in the past. If we look just at the biology of the disease and whose immune response is weaker, we're not going to get at these other factors that loom large.
Henry.
Yeah, I basically agree with that response. So our model is sensitive to those same risks, the risk of infection and the risk of severe disease if infected. But we capture it in terms of the bottom line, that is the likelihood of deaths of people of given ages. And an important point about this pandemic is it's constantly changing and surprising people in hotspots in surprising areas and in surprising ways. So it's very dynamic. And this is, I think, another problem with the WHO proposal is it doesn't build in enough sensitivity to this dynamism. It's going to be a constant need to track the evolving data. And so focusing on the bottom line is a good way to do that. There are lots of factors that are in play. Some of them will be the background, marginalized groups that are doing very badly, but then what else comes into play, you don't know in advance.
Nancy, one question came in that's more really a clarification of your presentation when you made a distinction between what it means to save the most lives when it comes to a life-saving intervention like the ventilator versus saving those most likely to die for a vaccine. So if you could just sort of expand upon that and clarify it so the audience gets the distinction you're trying to make.
Right, I'm very glad that question was asked. It's a very important distinction that I think is often overlooked when we're talking about the distribution of scarce resources in healthcare, because the same considerations are going to weigh differently for different types of resources. So the point of contrast that I made between allocating a life-saving resource such as a ventilator, where we, according to standard sort of triage, we would give highest priority to people who are most likely to survive if they receive that resource and die otherwise. But when we're talking about a preventive resource, such as a vaccine, we want to ask who's most likely to die if they don't receive that intervention. So who's most likely to die is going to be people who, for example, are older adults who are have a higher risk of dying if they get into with the SARS-CoV-2 virus, is one group. And so we focus on who's most likely to die without the intervention. And there we're talking about saving that life. Because if the older adult, in my example, the 70-year-old with type 2 diabetes, if they don't receive the vaccine and they become infected, they're most likely to die. And so the prevention should go first to them and to others that fall into that broad category.
And just to follow up to clarify for that question, if that same 70-year-old were to be infected with diabetes and other comorbidities, they might actually, because they would not be at highly likely to survive, let's say, may not get the ventilator under the.
That's exactly right. That's helpful.
So,
yes.
So that just helps to clarify it for that person. I think that's right. Good. Another question is about vaccine skepticism and whether questions of justice play into questions about vaccine skepticism and how each of you would handle that question.
That's a great question. I think it's a large concern here in the United States and probably around other parts of the world. I think it requires a lot of moral leadership and a lot of science-based decision-making around the release of vaccines and the process by which they're vetted. And distrust is obviously going to grow. It is growing in parts of the world where that trust is not present. Then there's not trust in the enterprise of research, and not trust that these decisions are being made on the sort of scientific grounds that they should be made on. I think many people are very concerned about that. And I don't think that models this model that we presented, that I presented during my presentation addresses that, but it's really when the rubber hits the road, that's really going to be critical, because no matter what allocation scheme we set up, if these are voluntary choices that individuals are going to make, they don't trust the enterprise and the research enterprise and the science of a country in terms of what's being released, and the incentives are wrong, if they're political rather than scientific, then we're not going to get very far. So I think I've been happy to see that some of the big pharmaceutical companies have stood up and said we are going to make decisions based on science. I think it's going to be challenging to stick with those standards, but I think that's one way in which we can have a broader conversation and try to reassure people that that will be the deciding factor.
Henry, anything to add on that?
Well, I think it is, yeah, it's a political problem more than an ethical problem, but it's interesting to think about this WHO proposal, the proportional allocation, and how that might play into that. On the one hand, that seems very transparently fair. I gave them reasons before why it is just an illusion of fairness, and I think people may see through that and see that it's a political decision they've come to. You know, WHO has countries as members, so it's easy for them to talk about, you know, treating every nation the same in the sense of giving everyone the same proportion of vaccine. But people may recognize that what really matters is the loss of life, however you want to measure that, and that this is insensitive to that. So that I'm worried might not do as well as it could to reinforce the trust from that angle. I think the Vaccine Alliance has done a great job with lots of the poorer countries, and probably is much better trusted than our own government is on this matter.
Okay, well, unfortunately, we're out of time. This has been a really great discussion. We could have kept going, I think, for longer. I'd like to thank both of you for really excellent presentations and responses to the questions. I want to remind those in the audience that this has been recorded, and it will be posted on the KIE website, kennedy-institute.georgetown.edu, in the next few hours to days. If the topic has been of interest to those out in the audience, you may also note that there'll be an ASBH section, a session on next Thursday, October 15th at 2:45, where Professor Jecker again will be presenting on age, as well as one of our graduate students here at Georgetown, and two medical students, one from Penn and one from Georgetown, on age and distribution of healthcare resources in a pandemic. And then finally, I think it's incumbent upon me to extend my thanks to Lucas Chandler and Professor Laura Bishop and the rest of the staff at the KIE who've helped so much to make this run smoothly. It makes my job easier. It made Nancy's job easier, Henry's job easier. I'll also thank our librarians who have great resources. If you want to also check those out on the Kennedy Institute's website for reading about vaccine pandemic justice and other questions related to the pandemic. So thank you very, very much. We really appreciate the presentations again and the participation from the audience. Have a great day and a great weekend.
Thank you.
Thank you.
Well, thank you, Nancy.
Thanks.